Ah,
Am I?
yes.
Yeah. Good evening, everyone. I'll be presenting regarding how a guide wire misbehaves at times when we insert a dialysis catheter. Or so to begin with, I'd like to share a few experience or all experiences. These experiences, some of them are of my own, but because I don't have images related to those, I've tried and pulled up similar like cases from whatever is present in the literature. And of course, there are several other guide wire mishaps that have happened, but I may not cover all, just touch base them. So before we dive into the topic, I'd like to discuss the anatomy because a lot can be explained about the guide wire behavior with the structural design itself. So there are three types of guide wires, that is solid core wire, mandrel wire, and ribbon wire. What the basis of each of this is that there is a central thin wire and there is a core like a spring wound around it. So that is the solid core wire. Then there is mandrel wire where the outer spring coil is at only one end. Probably the J tip end will only have the spring coil, and the rest of the wire will be just one central thin wire. And the third one is there is a ribbon like structure. So there are two central wires around which a coil is wound. Now these three, along with the structural design, that is, it can be straight tip, J tip, or angle tip. So most commonly we come across J tip in all of our dialysis catheters. So the reason why I'm stressing on this is because there was a video, I don't have it right now, where we could straighten the J tip by fractioning the body of the guide wire just because of this structural design. So the spring, if you press the spring on one angle, the J tip will straighten up because of these coil-like structures around a central wire. So that needs to be, when you open a catheter set, you will be able to recognize what guide wire are you dealing with. Now, we all know, but I'll just summarize as to what all a guide wire can do while we do catheter insertion. One is, of course, guide wires can cause arrhythmias due to mechanical irritation of the blood vessel or the cardiac heart walls. Then there is perforation of vessels or cardiac chambers. Kinking, looping, or knotting of the wire, of course, that is because either we are in the intravascular or the extravascular space. I'll further mention about it in the later slides. Then there is entanglement of previously placed intravascular devices, like if we have a pacemaker in situ, that can also cause entanglement with the guide wire. Then there is breakage of the distal tip of the guide wire with subsequent immobilization, or it can block the catheter tip. And lastly, of course, this is the most dreaded complication where there is a complete loss of guide wire within the vascular system. That can happen maybe because when we lose the proximal control of the wire and we just focus on threading the catheter, and that's how the guide wire is left behind. This has happened during my residency days, so I'd be discussing about it later. So the end result of all this is that there will be a failure to place the catheter. There will be catheter malpositioning. There can be bleeding, pneumothorax, and hemothorax. So a proper guiding the guide wire itself would help us do the procedure well. Now, just sharing my own experiences. The most common experiences is that the guide wire often goes astray. That is, let's say, just get a pointer. Okay. The guide wire, let's say if it is inserted on from the right IJV, sometimes it tends to go into the subclavian or in the opposite direction, and it won't go in the right atrium. Whereas even on the left IJV, when we insert the catheter, because of the loop, the J tip, it can go reverse in the opposite direction in the right IJV. I'm not able to answer. Yeah. So I'll just help.
That's fine.
Yeah. So
The
when we
we can.
insert it here, at times it will just curve like this, or it may curve like this. This has happened with me that one of the PGs has inserted a guide wire and she put the catheter also, and the catheter tip was like this. So then we had to pull out the catheter and we had to get another dialysis catheter set altogether. Another thing that happens is, suppose we go through the left IJV, sometimes it enters and it goes up. So in such situations, what we have done is that when the only control we have is the needle, introducer needle. So this bevel that you can see here, if you rotate if you rotate this part of the needle, the hub, and retract the guide wire at the same time, and then simultaneously rotate the needle hub, there is a possibility that you can successfully enter the right atrium and the guide wire will be in place. So that is about a misplaced or malpositioned catheter due to a guide wire. Second, next is the blood vessel damage. Usually, I think the blood vessel damage initially, a lot depends on the introducer needle. If we introduce if the introducer needle is inserted in an appropriate angle and it is free in the freely swimming in the blood lumen and not touching any blood vessel wall, then these minor tears that have happened in figure B, that may not get exaggerated by the guide wire itself. So let's say the introducer needle has touched any the vessel wall, there will be a minor tear, and then when you insert the guide wire, that tear will be exaggerated due to the guide wire insertion. Now, of course, when we insert this type of a event happens, there will be resistance. So it's always important that when you are inserting the guide wire, it goes in smoothly without any resistance. That will prevent lumen rupture or dissection of the blood vessel. Also, although we are nephrologists are dealing with veins and cardiologists are dealing with arteries, but we may puncture arteries also. So in that situation, we have to be very careful in case patient has atherosclerosis and there is a thrombus, then the guide wire can tend to embolize that thrombus due to forced insertion. Next is guide wire kinking. Now, this happens generally because suppose when we are inserting the the needle is gone in space, but when we are, after inserting the needle, when we put the guide wire and we change the angle of the needle, or after removing the needle, we thread the dilator over the guide wire and we change the angle of the dilator because we got some resistance, the guide wire can bend. So this bending can be harmful because although your dilator has gone in easily, then you have a dialysis catheter that has gone in easily. But the moment you're trying to remove the guide wire to check the blood flow, your guide wire gets stuck in the catheter itself. So it's very important to avoid any kind of excessive torque or tension that can cause bending of the guide wire. And then, of course, if we do repeated ETOs of a guide wire, let's say a guide wire has fallen because it's slippery, we use another guide wire, which is a spare one, which has already been sterilized. But a repeated use of sterilized guide wires, there can be rusting and they can lead to fracturing of guide wires if we use it repeatedly. Also, if there is a complex anatomy, there are tortuous blood vessels, again, guide wire can bend because it's not a rigid structure. Then devices like I said, catheter, dilator, sheath itself, if you're forcing the sheaths because of taut skin, or even if the incision what we've made is not big enough, then there can be bending of the guide wire. Next is this. I'm sorry for this yellow thing. This is a X-ray of an individual whose guide wire was extravascularly placed. Although there was no resistance, what happened is when they put the catheter inside, the J tip looped over itself, and then it kind of formed a knot. But this was after the introducer needle went well, there was good flow. When the guide wire is inserted, it probably went outside the into the extravascular space and caused this loop. Now, this loop can occur, as I said before, because of the wire material, the wire design also, based on if the coil is at the tip or throughout the guide wire, or tortuous vessels, or the technique used. Now, this is something I pulled off from the literature available. This is actually a referred case. Like the person who has published it got this from outside, that they had inserted a catheter. They tried to remove the catheter in this girl, but they couldn't do it. So they referred it to a higher center. And what they did was that this catheter was in extravascular space. It was not in the blood vessel. The patient was asymptomatic, and it was hanging in the patient, around the patient's neck. So in this situation, the surgeons had to take a deeper incision, and you can see there's a raw area, and then they could successfully remove the guide wire. In certain cases, you cannot untangle these knots. So that is why this larger incision has been taken and the whole knot has been removed en bloc. Next is, this has happened with us, but again, I've tried to get this from someone else's case report. So what happened was with this catheter was that two unsuccessful attempts were taken, right IJV and left IJV. Then they went ahead with the third attempt in the femoral vein with the same guide wire, which was used for the right and the left IJV. And they could thread the catheter very easily. But after they removed the guide wire and they were trying to draw blood to see the venous flow, there was absent venous flow. So and they had no choice but to remove the catheter. And when they saw the tip of the catheter had guide wire stuck to it, there was a fractured guide wire that is stuck to the tip. And that is why another catheter had to be placed. But this is again, like I said, because there was a lot of torque and torsion probably applied to the guide wire. And of course, using the same guide wire for the same procedure for the third time is not advisable. Next, this has also happened with us, that this, I think, if I'm not wrong, is an arrow catheter where they have
No, this is B Brown. This is B Brown, which has this.
Okay, yeah. So this, in this, while we were retracting the guide wire curved up, and because we have to draw blood from the port which has the coiled portion of the wire, we were not able to do so. And then again, the needle had to be removed. We had to get another introducer needle and another fresh guide wire, and then we had to proceed with a new puncture. So this is probably because the guide wire bent and then it curved up while removing or retracting it. Next is a lost guide wire. Now, my experience with the lost guide wire was that it was not with an HD catheter, it was with a central venous catheter. It was in the ICU. One of the residents, she put the catheter successfully. Everything went well. And then the patient started having arrhythmias. And when we saw on the X-ray, the guide wire was also in the thorax. So replicating that kind of a case scenario, I was surprised that there are many. I was not the only one. So they found the same situation with femoral catheters, where the guide wire went up to the IVC. It was also found in the neck region. Usually, such cases may be asymptomatic, but what you need to know, or what you need to, the signs of guide wire loss are basically there'll be a resistance to injection via distal lumen. There may be a poor backflow from the distal lumen, and of course, the guide wire is visible on the radiograph. So this particular case, I am still unsure how they removed this, but apparently the reason why I'm mentioning this is because it was a nephrology case. They haven't removed it by a snare or a basket catheter, that is the Dormia basket catheter. They have basically suctioned the blood, and the catheter was removed. The patient was in head up position, but I would like the house's opinion on how this must have been done. Also, a key point that needs to be remembered, that any point in time when we are inserting a guide wire, it's always important to hold the proximal end. If you lose the proximal control over the proximal end, the guide wire may be lost. And then you have to call up the surgeon to remove it. So the removal techniques, although I haven't seen it, but there is snaring. So snaring is you insert another wire-like structure like a probe, and then after you click it, the basket comes out like this circular one in A, and then this J tip is like it's just stuck in the ring of that snare, and then because it is what do you call it, piggybacking on that snare, it can be drawn and the catheter is removed. Similarly, Dormia baskets are popular for kidney stones, but these loops can help grab the J tip of the wire, or even the straight tip if it's possible, and then pull out the catheter. And these issues, because we've personally experienced them, I would like to discuss. One is reversing the tip, which is not at all advisable, because what has happened is sometimes, because we can't straighten the tip and that plastic cover is not there, which guides the J tip, and or we are not able to straighten the J tip, the people like residents tend to reverse the guide wire, and that straight portion, if you've noticed, is very sharp, or probably relatively sharper than the J tip. The J tip is softer because some of them will have the spring mechanism, the J tip, and the opposite end will not have any. It will just be a plain wire. So that can cause vessel rupture, and it is not advisable. Second is, this happened with me. I don't remember the company exactly, but the catheter guide wire went in, dilator went in, everything was smooth. But the moment we were trying to insert the catheter lumen had a plastic inside it. And that did not allow the guide wire to go in. We tried a lot of things, but then finally we had to end up with getting a Terumo wire, putting the needle again. And because Terumo wires are soft, slippery, and probably the size of the Terumo wire, I'm not able to recollect, but was smaller. So we could thread we were able to thread the catheter on the Terumo wire. And of course, as I mentioned before, if you use recurrent etiode wires, they have a high chance of fractures. So that is not advisable. And lastly, this is a video from Velarvin sirs. This is how exactly we want the guide wire to go in. It is smooth, there is no resistance. And what we need to remember is that we have to respect the angle of the wire. It sits at a particular angle. So if we change the angle by introducing the dilator and changing the angle of the dilator, it will cause bends. Also, what we need to remember is slight back traction on the wire helps when we are sliding in the dilator or the catheter, to avoid kinks, of course. Then in case you notice any kink before you put a catheter, it is always advisable that you rather replace the guide wire than proceeding with the same guide wire, because you may have problems withdrawing the guide wire after the catheter is in. Lastly, do not wrap the wire over the fingers on the wrist. There is a reason why that circular plastic sheet cover is meant, so that helps you guide the guide wire while insertion. I hope I've covered most of the points, and I'd like sir to.
Yes, thank you, Purva. I think we'll quickly move on to Dr. Hemant.